Helena and I are very good friends, so you may find that we're so friendly that some of our slides are very close together. All right, so what should we be measuring in PCOS? There are many things that we want to measure, and I've had a very good lunchtime discussion with many of you, with you telling me that you can't, or your patients can't afford to measure some of the things that we would measure in Australia. So we've got to take this into consideration, that the medical environment in which you work, the cost structure, who's paying for tests is very different across the world. But I'd like to go through some of the things that we think are important. So first of all, just to remind you about follicles in the ovary. So we've talked about the fact that these cysts are not cysts. They all contain eggs. And in my clinic and in other clinics, we can remove eggs from these tiny follicles and we can get babies because there are eggs in there. So we're looking at the development of follicles from primary follicles, and this is where the AMH is produced. So AMH comes largely from the very early follicles, the primary and the early oocyte. The granulosa cells are producing large quantities of AMH. AMH is not being produced very much from the large follicles that are about to ovulate. And so we're dealing with a patient who's got a very large number of follicles, usually in their ovary, if they've got polycystic ovaries, but they've got a follicle development that's reached a roadblock. And I use this analogy with patients. I say, it's like a roadblock. You've got something that's blocking a good quality follicle from moving forward. And what we've got to do, whether it's through lifestyle or through medication, we have to get past the roadblock. We've got to convince the policeman to take away the barriers so that you can continue to go ahead normally. We also all know this chart that you start off life with a large number of large number of follicles, and that they drop away as time goes. Now with PCOS, they're all tracking in the upper part of this curve. So patients with PCOS are starting off with more follicles, and those follicles are reducing slower than patients who don't have PCOS. So again, it comes back to the fact that we should be confident when we talk to patients who have PCOS, who are concerned about fertility, that all the ingredients are there. We need to recognize there are lots of good quality follicles. We need to recognize that the blockers can be reduced, and therefore the chances of fertility are still excellent. So let's go into some more detail about the development of ovarian follicles and what has an effect. So those of us who do IVF are used to using FSH. We kind of think that that's going to be the thing that removes the roadblock. But there are other things that are around. So for instance, each egg is producing a substance which is influencing the follicle itself, the granulosa cells. So these are things called GDF9 and BMP15, and we know that they're increased in PCOS. If we do immunostaining, we can see a lot more of these in the eggs. We know that FSH and many growth factors within the ovary promote follicular growth. And we have AMH, which inhibits follicular growth. The purpose of AMH is to stop follicles growing. And that's why the higher the AMH, the more difficult it is to do ovulation induction. And we've shown very clearly the higher the AMH, the more difficult it is to get lifestyle to work. So a very high AMH is not only an indicator of lots of follicles, but it's also an indicator that treatment may be more difficult because that is blocking the growth of follicles from this stage through to this stage. So just to summarize, what's going on in the ovaries? Well, we're not dealing with cysts. We're dealing with arrested follicles, which are less than 10 millimeters, remembering that most follicles will ovulate between 18 and 24 millimeters in size. All of these antral follicles should theoretically have an egg in them, And that's exemplified by the fact that you can do in vitro maturation on most of them. All the follicles are endocrinologically active, which is different from a cyst. They're producing testosterone, and the byproduct of that is estrogen. We know that if we do a laparoscopy and we compare what we see on ultrasound with the laparoscopy, there's a very good correlation, and therefore ultrasound is a better way to go than laparoscopy. And we know that there's a communication between the granulosa and the thecal cells to produce hormones. So as a consequence of that, we take our 3 Rotterdam criteria, and this has been shown by several people already. If we take irregular cycles, we take polycystic ovaries morphology, and we take androgens, we get overlaps and we get different profiles. And this is the so-called spectrum of PCOS. There have been a group of people, particularly in America, that don't necessarily like Rotterdam, so they produce A, B, C, D, E, F criteria. They're all based on this particular diagram. But when you look in the Western world, and there's not a lot of data, I think, from South Asia, but I'd be interested in it. If you look at where you've got all 3 of them, you've got around about 60% of patients have got PCOS with all this. And so this is more of the so-called NIH criteria that is more severe. We have other patients who've got hyperandrogenism and polycystic ovaries, but they have normal cycles. They're still part of the PCOS spectrum. Then we get others who have anovulation, but polycystic ovary morphology. They're a smaller group. And then we have others who have no evidence of an abnormal ultrasound, and that's, with these 2, tend to produce the NIH criteria. We've heard today about the prevalence of PCOS. We think in Australia that up to 20% of patients have got polycystic ovary syndrome, particularly if you take our indigenous population. If you take different criteria, AE-PCOS or NIH, then that number drops somewhat. And prevalence studies have not been very well done around the world. I think Sri Lanka's been done well. We've done some good studies in Adelaide, but we need to be doing more on what is the true prevalence. So what are the key issues in PCOS? Well, firstly, we've got to get the diagnosis right, and that's what I want to talk about today. Then we need to do appropriate testing of the woman, and I'm just going to say a few words about the family, because there's more and more evidence now that brothers and sisters, and indeed mothers and fathers, have higher risk of disease as well. We need to manage insulin resistance and its consequences, and that's not part of my lecture today. We've realized, particularly in Australia, that psychological, emotional and cosmetic effects are highly important to patients, and that'll be covered later. And then the concept of reproductive life planning, including fertility, even in a person who's not thinking of having children for a long time. So let's deal first of all with menstrual cycles, and Helena covered some of that and the guidelines today. But basically in adults, we'd normally say that if it's 21 to 35 days, that's within the normal range. You need to recognize that not everybody with regular cycles is ovulating. So that can only be checked by progesterone or ultrasound or whatever you choose to do. You can largely assume they're ovulating, but you cannot make it categorical. Then you may get signs of ovulation. A patient may say, yes, every month, around about 14 days, I recognize that I get vaginal secretions, I get pain for a couple of hours, etc. Then you get some people who use urine LH sticks, and in our society a lot of women will do this to see if they can pick up the urinary LH. Luteal phase progesterone, appropriately timed, is important, we're trying to train our doctors around the country that day 21 progesterone is not necessarily right. It's 7 days before an anticipated period. And we get a lot of patients who are sent to us as being anovulatory, day 21 progesterone is low, but they're having 35-day cycles, so that's why it's low. In my clinic, as well as probably in your clinic, some people choose to have their whole cycle tracked. So they have their bloods done on a regular basis, they have ultrasound. We can time to within hours when they're ovulating. We can document the whole cycle. That's expensive. It uses a lot of medical resources, and probably in the environment you work in is not very feasible. And then obviously pregnancy is the ultimate test of ovulation. Somebody who has a period once every 10 years, who gets pregnant, ovulated at least once in that time. The problem comes with adolescence, and we've heard a little bit about this before, that cycles are often irregular, and therefore we assume that they're not ovulating, and often someone who's sexually active thinks because they're only having 1 or 2 periods a year, they're not ovulating, and that leads to unwanted pregnancies. So there was a study done in Perth with Roger Hart and his group, where they looked at 40 girls to see what was happening to their cycles. They had 32 patients that they documented ovulation on, and they did daily urinary pregnenolones, and they had 6 who they documented no ovulation on. But it's interesting that some of the girls who had cycles of over 45 days regularly ovulated, even though their cycles were long. There were others who were under 21 days, and a number of them, or the majority of them, were still ovulating. So you cannot assume that just because a cycle is long or short that someone's not ovulating. You may actually have to document that. So if we look at this particular chart, and I'm indebted to Dr. Larvin for this data, if you look at adolescent girls and the percentage of girls that are anovulatory within 1 year of having their first period, you'll see that the majority are anovulatory, but as time goes on, they become more and more ovulatory. So this is a time factor. As a teenager, it takes time to get regular cycles. However, even within a year of your first period, you can ovulate. And then if we look at patients who had PCOS, who developed PCOS, you'll see here that a number of them had less than 21 days, and then the rest of them had over 32 days. But look at this, you still could have PCOS and ovulate, and therefore in an environment where sexual activity is prevalent, this is a chance of pregnancy. And then if we look at the number of irregular cycles in women with PCOS, once they get through adolescence, then again we recognize that amenorrhea and oligomenorrhea is common, but remember there's still a number of people who do ovulate. So irregular periods, lack of ovulation, it's only one criteria with PCOS. You can ovulate and still have PCOS according to the Rotterdam definition. Then we move to ultrasound. And ultrasound, as we heard this morning, is very controversial. It's very subjective. It depends on your equipment. So there was this task force. This is probably the best current paper about PCOS morphology. But it's now getting a bit dated. I think this is 2014, and things have moved on. Now, I'm not sure if you've got in front of you a piece of paper here. Duru, have these been distributed? It says fertility assessment scan. People haven't got this? You haven't got it. It was supposed to be distributed, so I'm going to have to go through it with you. I'll just take you through this. So these are the recommendations from the AE-PCOS. They recommend it should be 25 follicles. The new guidelines are talking about 18 follicles. Ovarian volume is still quite useful, so anything over 10 mils is useful. And AMH is not yet there as a surrogate for the ultrasound. So all of you are used to what a polycystic ovary looks like. However, I'm sure the majority of you practice the way I used to do. You just do a quick scan through the ovaries. You say, this looks like polycystic ovaries, and that's it. You may not measure the volume. You may not count the follicles in a systematic way. But that's really what we need to be doing these days. We need to be doing a proper ultrasound. This slide was shown earlier today, just showing that as time goes on and we get better and better equipment, so we realize that there are more and more follicles that are picked up in normal women, and therefore are the definition for PCOS. So the Rotterdam criteria talked about 12 follicles per ovary. For all of you, that's completely out of date now. You've got equipment that's much, much better, and therefore it's going to be either 18, or it's going to be 25, or it'll be even more than that. All right, so what do we want as clinicians for ultrasound? So I'd suggest that this is the report, whether you do it yourself or whether you send off to a radiology department. You want the ovarian volume for both ovaries. So you want someone to measure 3 dimensions and to give you a volume, because that is very useful as an indicator. Secondly, you want a proper antral follicle count. It's not just a quick look through, yes, subjectively this is okay. You actually need to work systematically through and count the follicles as you go through. And it's worth getting a comment on the follicles and the stroma that are there. And it's also mandatory to get endometrial thickness, to actually measure it. So the report should be quantitative and not qualitative. I send patients off to a radiology department if I'm not doing it myself. And I'll sometimes get a report, both ovaries are present, the uterus is present. That's the report. That is utterly, utterly useless. It's a waste of money. And there are things that I want in the report that will help me with my decision making and help the patient as well. So the report must be on polycystic ovary morphology, and also we should get a visual record back. Now, how many of you would send a patient off to a radiologist or ultrasound department and rely on that? Perhaps you could just put your hands up. Is it common in India that you would send someone off somewhere else? Or would all of you do your own ultrasound? How many of you would see patients where they bring in a report from outside? Okay, so a lot of you, and that happens to me as well. All right. So there's special circumstances where things can be different, and again, that's been highlighted this morning, that in adolescence, you cannot rely on the traditional definition of polycystic ovaries, because they've got many follicles, and therefore you cannot be sure at this stage whether they've got polycystic ovaries. We also have the effect of age. If you only see a patient for the first time when they're 35, the criteria will be different from when they're 15. Some people have recommended 3D scanning, and although that's very fancy, it hasn't taken over at all. The oral contraceptive pill may reduce the number of follicles and ovarian size. And we also need to be aware that you can have hypothalamic problems and also polycystic ovary morphology. That does not mean that they've got polycystic ovaries, polycystic ovary syndrome. So we may get a woman who is very thin, perhaps anorexic or bad eating habits, and she's got hypothalamic amenorrhea. Her estrogen is low, her gonadotrophins are low, and she's got polycystic ovary morphology. That does not mean she's got PCOS. And then we've got difference in equipment and personnel. What you measure may be different from what your colleague measures. All right, so we have been working on trying to get recommendations for reporting pelvic ultrasound across the country. And a piece of paper that was supposed to be with you is not with you, but will. Okay. But it's probably going to come too late for me to go through with you. But you'll find that this is a 3-page document which we're going to trial in South Australia and then hopefully across the country, where we as specialists will demand of a radiology or ultrasound company, we will not send you any patients unless you give us a report that fulfills these criteria. So these criteria talk about what we want described in the ovary, what we want described in the uterus, in the myometrium, looking for adenomyosis, and a number of other things, endometriosis, to what extent that can be done. So when you get this, you may find this useful to go through and even to institute it in your own personal practice. But it includes asking the patient some fundamental questions, which we expect the ultrasound doctor to ask the patient before they scan. The ovaries. So I'll just tell you what we want from the ovaries. We want the volume. We want the antral follicle count, where they've scrolled through the whole ovary. We want them to comment on whether the follicles are uniform in size, whether they're central or peripheral. We want any follicles larger than 10 millimeters well measured. And we want documentation of any large cysts. We also want the organ mobility. We want the ultrasonographer to tell us whether the ovary moves or not, whether the pouch of Douglas is obliterated, and we want the endometrial thickness. So those are just some of the things, but when you get this bit of paper, you'll see that there are a huge number of other things, most of which we personally don't do, but I think we need to start to do. Because if someone's paying a lot of money for an ultrasound, they need to get a definitive answer. All right, I'm going to take you through a little bit on AMH now. We know from the guidelines we're not recommending AMH to take over, but I do want to talk about AMH because I think in time it will become equivalent to ultrasound in our diagnostic criteria. So we know that these small follicles I've talked about will grow under the influence of FSH. One will grow through to be a normal follicle, and the others, as the estrogen rises, get suppressed, and because they don't have enough FSH receptors, they don't grow. So what does AMH do? AMH regulates how the follicles come out to be recruited and to be interrogated and to be chosen. So AMH is incredibly important at regulating the exit of small follicles into large follicles. So this is what we think AMH does at the moment. We think it controls the transport of primordial follicles through to preantral and antral follicles. We think it has an effect on making androgens to become estrogens. And we think it also influences the effect that FSH has on the follicle. So AMH has a big role within the ovary. It controls the rate of follicles coming out and how sensitive they're going to be to endogenous or exogenous FSH. We can stain for AMH in the ovary, and you'll see that the small follicles have a much bigger stain than the large follicles. Now, what's particularly exciting is that we now think AMH may be a circulating hormone, that it doesn't just work within the ovary, but that it works in the hypothalamus. Now, all this data is rat data, so at the moment it's not proven. But what we think happens is that there are AMH receptors on the GnRH neurons in the brain, and that AMH circulates and influences the way that these neurons affect the pituitary gland. And so it alters GnRH release pulses, and you'll know that to get release of FSH and LH in an organized fashion, you've got to have pulses of GnRH. And it also affects what goes on in the ovary. So if this is true, AMH is a circulating hormone that not only causes delay in the ovary, but may cause delay in the hypothalamus. And this opens a whole lot of new therapeutic possibilities for us as time goes on. If we can neutralize AMH in the blood, we may well be able to cause ovulation to occur in the hypothalamus. So what do we know about AMH and PCOS? Well, PCOS has high ovarian reserve, and if we measure AMH in the blood, we know that PCOS has much higher levels of AMH than controls do, and we know that the antral follicle count is much greater in PCOS than it is in controls. We've also got data on AMH receptors in the granulosa cells, and Dr. Lavin's group can show very clearly that there are more AMH receptors in the granulosa cells of patients with PCOS than there are in controls, and there are more AMH receptors in obese patients than thin patients. So not only do you have more AMH being produced, but you've got more receptors to act in the granulosa cells. So why do we use AMH for ovarian reserve and possibly in the future for PCOS? Well, there's no circadian variation. There's not a lot of menstrual variation. The pill has some effect, but it's not very marked. It's quite a stable hormone, so you can leave it out for a while. It doesn't cross-react with any other hormones, so you don't get confusion as you do with some of the androgens. It's quite reproducible. There are a lot of kits around. And the other exciting thing now, and I'm not sure if this is available in your center, it can be automated. So the way that they measure TSH and many of the other hormones is automation. They just put it in a machine and it does it all. AMH can now be completely automated. You don't use the old methods for it. So it's a prediction of incipient ovarian failure. It's a prediction of polycystic ovary morphology. As you all know, you use it to decide your dose for FSH, for IVF. You can use it to avoid hyperstimulation and over number of follicles on ovulation induction. You can use it for planning egg freezing, and it's also used for intersex assessment in young children. But there have been a lot of practical problems with AMH, and I'll just take you through this. So first of all, you have to have age-related values. So the lab that you're dealing with needs to have a record of what happens with age. And I think you all know this, that an absolute AMH value is no good. You have to relate it to age. There is some concern about whether it does change with menstrual cycle, and there's increasing doubt about BMI and the pill. Most of the results that are in the literature are using a test called the ELISA. So this is an enzyme-linked assay, immunoassay. And the first results were all with ELISA and were pretty reliable. The only problem is that they're manual. So you have a person who's pipetting into dishes, and that is less reliable than a machine doing the whole job. For about 3 or 4 years, we had a stage where no one trusted the AMH assays. I think that was from about 2011 to 2014, because the stability of the AMH was doubted. And so a lot of the literature that we've got now is around assays that we don't now trust. There's good association between ELISA that's well done and automation, but there's no international standard for AMH. So these are the assay problems that we have for AMH. So some are physiological, so the age and maybe the menstrual cycle, the fact that AMH might be produced by a tumor that's developing. Then we've got things that we do to the patient, like giving estrogen or progesterone. Then we've got analytical problems, so that's how it's frozen and what happens in the laboratory. We have things to do with temperature and the way that it's handled. The kits have got slightly different antibodies, so that's a problem. So all of these impact on AMH. Now, if you have an automated system that everybody uses, it's more reliable. So this is what we term a receiver-operated curve, looking for the diagnosis of AMH and the diagnosis of PCOS and PCOM. So the higher this goes up and the closer to the top here, the better the assay. If you have a line that just goes across there, that's random. So this is quite a good result using a number of published results. And we can choose a level at which we can say it's likely to be polycystic ovary morphology or not. And again, this is from the Dutch. So they've taken 4.7 nanograms per mil as being something that will differentiate with a reasonable degree of separation between polycystic ovary morphology and normal. Now, I'm not sure what you use in India. We use to picomoles. Do you use nanograms per mil or picomoles? All right, so nanograms per mil is that. If you take picomoles, this is around about 33 picomoles per litre. But this, again, is age-dependent, and we don't have a lot of data that relates this sort of table to different ages. It's also important to recognize there are different assays. So you need to know which assay your laboratory is using, and you should ask, which assay is it? So there's this one called the Gen 2 assay. This is an ELISA. This is called Access AMH, and this one is called Alexis. So they're just different kits that are used. And this is antral follicle count. And you'll see that for all the assays, there's a pretty good correlation between antral follicle count and AMH. So any assay that's around at the moment correlates quite well with antral follicle count. However, when we compare these individual kits, so this is the automated one and these are the manual ones, and you look at how they relate. If you've got a high antral follicle count, then they give you roughly the same results. And this is what we're interested in polycystic ovary morphology. If you've got an intermediate result, that's a person who's control, let's say, who's normal age and normal follicle number, they're not too bad, they correlate. But if you're dealing with low antral follicle count, incipient ovarian reserve, then there is a significant difference between the automated and the non-automated methods. However, this is quite reassuring that if you've got a lab that is very, very high quality, that almost any assay will give you good enough information to make a suggestion of whether there are a lot of follicles there or not. And I do want to recognize that, say again, that the international guidelines do not recommend that you use AMH instead of ultrasound at the moment, but I'm sure in time we'll review that. Clinical hyperandrogenism, you've seen this slide before. The classical Ferriman-Galway approach, from which this sort of picture arose, was in English from people from the UK, and there are a variety of cutoffs. Usually we use 8 as a cutoff. I would say the majority of gynecologists do not go and do a proper score. I certainly used to. I used to have these charts sitting in my clinic and I'd put a tick against all the scores, but my experience is 99% of gynecologists do not do this. I would suspect more endocrinologists do it, but by and large it's not done very well. But we need to look on this as being a very important component, because if we have a high score for hirsutism, then you probably don't need to get an ultrasound or even an AMH. It has been thought and is thought now that there are differences ethnically. So in Southeast Asian women, you probably need a higher Ferriman-Galway score. And certainly in East Asian women, Japanese and Chinese, hirsutism is quite uncommon, but acne is very common in those groups. So this is going to be ethnically variable. And that's shown in the study from China, where they looked at the mean and the various centiles, cutoffs. And you'll see here that the mean value was not a lot different across patients with PCO and those without PCO, but the 95th centile was different. And the important thing is to recognize the effect of age, that as you get older, so your Ferriman-Galway score cutoff may change. Let me take you on to testosterone. I'm sure all of you who measure testosterone, you put it in a tube or you send them to a laboratory and you trust the result that comes back. So I want to tell you not to trust testosterone results, and you need to be talking to your laboratory about what they're doing. So there are a number of methods that are used for testosterone. The one that Helena talked about briefly this morning, which we've always thought is the best, is called liquid chromatography mass spectrometry. It's a very complicated method. It's quite expensive to do, but up until recently everybody thought this is the only thing that you should do. So I think in Melbourne, Helena's got access to LC mass spec. I don't have it in Adelaide. In the US, if you want your patient to get it, it's around about $100 or more. Equilibrium dialysis is the gold standard, never used clinically. And then people who publish on testosterone, like Rick LeGros and others from the US, they extract it, and sometimes they do chromatography with immunoassay. So what are the practical methods? Well, you can do testosterone with SHBG, but everybody at lunch has told me we can't afford to do SHBG. We don't do SHBG in India. So a total testosterone may be value. Free androgen index, you need SHBG. And there are various methods for calculating testosterone, if you know the albumin, etc. The worst methods, and I don't think these kits are available anymore, they say they can do free testosterone. And these have been shown to be worse than tossing a coin. But again, you need to ask your laboratory about it. Measuring DHEAS and androstenedione is probably not very valuable. Some people use it in certain circumstances, but if you can't afford an SHBG, you can't afford these. This shows the relationship between LC mass spec and testosterone. Very, very close relationship, but the results are much lower with LC mass spec. Androstenedione, again, very good correlation. So this is a study that I did with colleagues in the Netherlands. And at the end of the day, in that paper that we published about 3 years ago, we said a good testosterone done by a good laboratory by immunoassay is just as good as LC mass spec. Then Helena and I have a friend called David Handelsman, who is a very vocal and high-profile person who's interested in testosterone. He was absolutely convinced that LC mass spec was the best way to go. So we gave him some specimens, and he went into it totally believing he knew what the result was, and he went into it. And we did everything by testosterone immunoassay, LC mass spec, and at the end of the day, and I won't go through this table in detail, we found no difference between the two methods. So even he now is convinced in women with polycystic ovary syndrome, a good quality testosterone assay, and I want to emphasize good quality, is probably just as good as a LC mass spec. And if you go back in the literature, a good friend of ours, Rick LeGros, did exactly the same thing. He sent it off to a commercial company, he sent it to their local laboratory to do LC mass spec, and then he did the immunoassay in his laboratory, and I think you'll see that there's virtually no difference between them. So at the moment, the people who can afford it think LC mass spec is what should be done, but the evidence is missing at the moment. So these are the diagnostic dilemmas we've got. When somebody gives us a menstrual history, are they ovulating? If you've got doubts, you probably need to do some progesterone measurements. If the ultrasound says they've got polycystic ovaries, you need to say, do these meet the criteria that we're expecting? And if they've got raised androgens, can you really trust the laboratory that you've sent them to? And is it worth doing SHBG and getting a free androgen index? So those are some of the diagnostic criteria that we need to look at. So those cover the three major Rotterdam diagnostic criteria, with maybe AMH coming in at a later stage. What else should we measure? Now, Chandrika and Helena will go into much more detail with this, but we will have younger non-pregnant patients, we'll have patients who are pregnant, and we'll have those who are post-reproductive. And the issues that we are facing, from what we understand of the pathophysiology of PCOS, is that there's insulin resistance and potential glucose intolerance. Hyperlipidemia and low HDL is more common. Diabetes mellitus is more common. Cardiovascular risk factors are alleged to be increased. And we've heard about non-alcoholic fatty liver. So these are some of the metabolic criteria that we need to work out. So how do we go about that? Well, we've got to be convinced that diabetes is more common. And so this was shown by Lisa Moran this morning. And this is a study of all the major data that we had at that stage, looking at diabetes mellitus versus PCOS versus controls. And you'll see a fourfold increase in diabetes in patients with PCOS. This has been updated recently, and it still holds. If you BMI match them, so you take away the effect of BMI, you still see a fourfold increase. So this is not just a weight or BMI. Metabolic syndrome, Chandrika has talked about. I'm sure we'll hear more about that. We know that that's increased in PCOS. So these are some of the minimum data set that I think we need, in addition to the diagnostic criteria. We need to get the BMI. I'm not sure if you measure BMI. It may sound strange, but many clinics, many fertility clinics in Australia don't measure BMI. They just look at the person. Waist circumference may be valuable and may be more valuable than BMI. An oral glucose tolerance test in certain groups of women, and again we're going to hear about that and have heard about it, is almost mandatory. And because many of us are seeing patients who want to get pregnant, we want the glucose to be maximally controlled before they get pregnant. Because even getting pregnant with a glucose in the upper limit of normal increases the risk of congenital abnormalities and diabetes in pregnancy. So we've got to get the sugar under really tight control. So I advocate every PCOS patient who wants to get pregnant should have a GTT. But we'll be reminded as to what the guidelines tell us. And it needs to be repeated. It's no good having a person with a BMI of 28 being told they've got a normal GTT, and then they come back 2 years later and we think we've done it. It needs to be repeated. And I personally think every patient needs to have fasting lipid profiles, even if it's expensive for you. I think it's really important. And these are the things that you might say are optional. Hemoglobin A1. I had a patient the other day who said she'd had 3 GTTs, and every time she had vomited, and she would never go back and have another GTT. I've got to accept a compromise of the hemoglobin A1. Insulin, we've heard stories about. I've got one doctor who, in my clinic, who does insulins on everybody. And I say, why do you do that? Oh, well, we can show them they've got a bad result. That motivates them. Well, bad results are not necessarily the good reason for doing tests. If we tell people they're insulin resistant, do we have to measure insulin? Liver function tests, I think the physicians and Chandrika would say these are mandatory, AST, ALT. I must admit I don't do them very often, but maybe I should. A liver ultrasound, I can't think the last time I did it, but I'm guided again by the internal medicine physicians as whether we should do that. So we might ask Chandrika and Helena later on whether they actually do liver ultrasound. And sleep studies are recommended, but again we heard this morning that even if you've got obstructive sleep apnea, which is common, that intervention doesn't seem to make any metabolic differences. So this would be my minimal data set for assessing metabolic problems, and then the minimal data set for diagnostics is ultrasound where warranted, having a quality testosterone result, doing good hirsutism clinical assessment, and getting a good menstrual history and working out whether those cycles are ovulatory or not. So I think I will end there. Hopefully there's enough controversy in there to keep you going for the next 16 minutes. Thank you.